Good evening, everyone. My name is Imad Sawiris, and I am an orthopedic professor from Cairo and the secretary of the Arab Board Scientific Council. It is my pleasure to start this review course with my greatest challenge, trying to change a boring, difficult to understand topic into an interesting, informative presentation. Let's start with this case scenario. This is a 44-year-old male patient who fell playing football. He had this IM nail 22 years ago with no problems. Looking at these x-rays, what do they tell you about the mechanical properties of the bone and the nail? In a separate piece of paper, try to match each of the terms in the middle with the corresponding box. We will come back to answer this example later in the lecture. So, by the end of this presentation, you should all be able to define mechanical, structural, and material properties of bone and commonly used internal fixation devices. You should appreciate the influence of mechanical environment at the fracture site on the mode of fracture healing and be able to apply the learned principles to the different fracture locations and configurations. A force applied to a body either causes it to accelerate or results in its deformation. If one plots a graph of displacement due to the force applied to a structure, the slope of the curve represents the object's stiffness. A typical curve has a linear elastic region. In this region, the object returns to its resting state if the force is removed, like a rubber band. Stiffness, again, is the slope of the elastic portion of the force displacement curve. As more force is applied, the object behavior becomes plastic and permanent deformation occurs. The object will not return to its original state after the force is removed, like when you bend a plastic ice cream scoop too far, it stays bent. The area under the curve represents the energy absorbed into the object during the deformation process. To standardize material properties irrespective of dimensions of the object, one divides the force applied by the area to calculate the stress, which is F over A. Strain is the change in the material's length due to the applied stress relative to its original length, so delta L over L0. If one plots the resulting strain, delta L over L0, due to the applied stress, F over A, the slope of the resulting stress-strain curve is the elastic modulus. Although the curves look similar, one has to differentiate between the structural properties and material properties and use the appropriate terms to describe points on the curve. Structural properties are the ability of an object to resist deformation under bending, torsional, or axial load. It is a function of the shape and of the object and the distribution of material around its cross-section, while material properties are fundamental behaviors of a substance independent of its geometry. The definition of these previously described terms is hereby stated. The other important terms to learn on the stress-strain curve are E, which is the elastic modulus or Young's modulus. The steeper the slope, the stiffer the material. A material with a flat slope is flexible. The point on the curve where the material changes from elastic to plastic deformation is the yield point. At some point, the material will break. This point is called the material's failure point. Here are the definitions once more. Therefore, a material which experiences little plastic deformation before it fails is said to be brittle, like glass, or bone in the case scenario we have shown. Materials with a large plastic deformation region before it fails is said to be ductile, while, like the nail, for example, in this X-ray. A material which can absorb more energy prior to failure, indicated by a large area under the curve, is said to be tough, while a material which can only absorb little energy prior to failure, indicated by a small area under the curve, is said to be weak. If we then try to match the terms to their corresponding boxes, we find that the nail is tougher, stronger, and more ductile, while bone is more brittle. We cannot judge the stiffness of either the nail or the bone from the X-ray. Hence, we need to calculate it from the stress-strain curve. Here are typical elastic moduli of common material encountered in orthopedic surgery relative to each other and to bone. The stiffest material we use in orthopedics is ceramic. If you knew that the next three materials, number 2 to 4, are metals commonly used in orthopedic implants, could you arrange them from the higher to the lower stiffness? That is absolutely right. The material next in stiffness is cobalt chrome, followed by stainless steel, and then titanium. So far, we have been considering material properties at a constant loading rate. Many biological materials, including bone, reveal different stress-strain curves depending upon the speed at which force is applied. This is called viscoelasticity. Some materials like bone have different material properties depending on the direction of the applied load, whether it's transverse, longitudinal, or shear. These are described as anisotropic. In addition to having viscoelasticity, the bone is also anisotropic. Its modulus is dependent upon the direction of loading. Bone is weaker in shear, then in tension, then in compression. Bone is therefore strong and stiff. This stiffness depends on the direction of loading, hence described as being anisotropic. Material properties of bone vary with age. Let's now try to understand how fracture fixation affects bone healing. Bone is said to be, as we said, is a strong material, but it breaks under very little deformation, 2% strain. When a mechanical load is applied to an intact bone that exceeds the structural integrity of the bone, a fracture will occur. If left alone, a fracture will heal naturally. A surgeon has the option of intervening with surgical stabilization of a fracture. Internal fixation of fractures alters the biology of fracture healing. The type of fixation applied, the amount of stability achieved will determine the type of bone healing that will occur. Under normal circumstances, a hematoma forms initially at the fracture site. This contains macrophages which clear dead tissue and mesenchymal stem cells which proliferate and differentiate. Inactive, flat bone lining cells enlarge into active polyhedral osteoblasts. With subsequent microvascular ingrowth, granulation tissue is formed which matures into fibrous, then cartilaginous tissue depending on the mechanical environment. Bridging callus matures from soft unmineralized osteoid to woven and later lamellar bone. Continuing remodeling involves osteoclasts, resulting in restoration of the bone shape and strength. The increase in cross-section which occurs with callus formation produces low tissue strain and higher stiffness compared with primary bone healing. The type of bone healing is determined by fracture complexity, type of stability, and the fracture gap. During the healing process, the tissue formed depends on the strain environment at the fracture gap. As the fracture becomes more stable, tissues with progressively less strain resistance are formed. Given that any displacement is referenced to the original gap in order to calculate the strain, a smaller gap will have a larger strain given the same amount of movement at the fracture site. Thus, simple fractures are best treated with reduction and compression, resulting in absolute stability. In the absence of micromotion, primary bone healing results with no callus formation. Simple fractures with small gap but no compression will have poor healing capacity, while on the other hand, multifragmentary fractures with larger fracture zone have smaller strain with relative stability. This induces secondary healing with callus formation. Absolute stability, therefore, is required for articular and simple fractures, denotes the absence of micromotion under physiological loading. It requires anatomical reduction, typically through open approach. This leads to direct bone healing and is best obtained by compression. We have two types of compression. Whereas in dynamic compression, the bone ends are subjected to more compressive forces as the limb is moved, the amount of compression remains constant during the postoperative period in static compression. As the bone ends are compressed with no or small interfragmentary gap, the osteoclasts will migrate along the Haversian canals like cutting cones, followed by osteoblastic bone formation, resulting in bone remodeling and direct healing with no callus formation. Absolute stability can be achieved with screws and plates. A lag screw produces interfragmentary compression, while axial compression is achieved with plates. Remember that some plates, the same plate will exert a different function depending on the mode of application. A lag screw produces interfragmentary compression. This could be protected with a neutralization plate as in the figure. In a transverse fracture, axial compression can be achieved by the compression unit of a DCP or LCP plate. A lag screw could be added through the plate. Tension band principle applies to any eccentrically loaded bone either by wiring or through a plate, provided that the compression surface is intact, but while buttressing is required if the bone is loaded in shear. The lag screw principle is one of the most important concepts of internal fixation. Any screw except locking screws can function as a lag screw. The application of a lag screw is a technique of how the screw is inserted and not the type of screw itself. A lag screw provides interfragmentary compression up to 3,000 newtons between the two bone ends, resulting in absolute stability. The technique which should be followed meticulously includes 6 steps with gliding hole, thread hole, countersink, screw measurement, tapping, and then the screw insertion. Relative stability, on the other hand, is achieved through the principle of splinting, whether locked or unlocked. This, in turn, might be done through external means, such as plaster, cast, traction, or external fixator, or through intramedullary devices, whether locked or unlocked. A common way to obtain locked splinting nowadays is through locking screws. Locking screws, which lock into the plate, produce angular stability. If a conventional screw is utilized as a lag screw, this should be done before any locking screws are inserted. Remember, lag before lock. Angular stability allows force transmission from one bony fragment to the other without the need to compress the plate onto the bone surface. This prevents primary loss of reduction if an inadequately contoured plate were fixed to the bone with conventional screws. Postoperatively, locked plates prevent secondary loss of reduction with rehabilitation. Remember to avoid a short middle portion of the plate to prevent stress concentration and fatigue failure of the plate, and to respect the principles which govern plate span ratio and the screw density. I believe that questions will be asked at the end, so in summary, we have to understand that the spectrum of stability and the mechanical environment allow the surgeon to select the appropriate type of fixation and obtain the desired mode of bone healing. Thank you very much, and I'm indebted to all these for the preparation of the material of the lecture.